Welcome to today's program, Cancer Moonshot, Symptom Management and Funding, brought to you by the National Coalition for Cancer Survivorship. My name is Eric, and it is my pleasure to be your moderator for today's session. For technical assistance, please send an email to canceradvocacy@compartners.com or send a message in the chat box. Today's program is scheduled for 60 minutes and includes a question and answer segment. Please note that today's session is being recorded and all participant lines will be muted during the session. If you need assistance at any time during the program, please select *0 and the operator will assist you. During our designated Q&A break at the end of the discussion, you may ask a question by selecting *1 on your telephone keypad or by typing your question into the chat box area located on the lower left corner of your screen. These instructions will be repeated later in the program. To interact with the presenters, you may submit a question at any time by using the chat feature located on the lower left side of your screen, and your questions will not be viewable by other attendees. If you look to the left of the screen, you will notice the links area where you'll find resources related to today's program. If you would like a copy of the presentation, click on Slide Presentation to open and print a copy of the slides. And now it is my pleasure to introduce today's first speaker, Shelley Fulnasso, CEO of NCCS. Shelley, welcome to the program. Please begin.
Thank you, Eric, and thank you, everyone, for joining us today. We are very happy to have two wonderful speakers today, Dr. Deborah Mayer and MK Holohan, to talk about the Cancer Moonshot and the survivorship and symptom management pieces of the Moonshot proposal, and to talk about what kind of the landscape on Capitol Hill as legislators come back after the election to consider funding for NCI and other federal agencies. We at NCCS have been following the progress of the Moonshot since it was announced in January, and we're very pleased that the Blue Ribbon Panel, which submitted its report last month, included a recommendation for symptom management for cancer patients and survivors. There's much focus on cures for cancer, which is very important, but we're very pleased to see this focus on the quality of life for people living with and beyond cancer. And one of the people who really helped champion that was Dr. Deb Mayer, who was a member of the Blue Ribbon Panel and also a member of one of the working groups that I had the pleasure of sitting on with her, and that actually made this recommendation. So I'm very pleased that Dr. Mayer is here to talk to us about the Moonshot overall and about the symptom management piece of that recommendation by the Blue Ribbon Panel. So I'm going to turn it right over to Dr. Mayer.
Thank you, and thank you for that lovely introduction. I want to say that it was quite an experience to be part of this august group trying to tackle the question that Vice President Biden gave to us about accelerating progress in cancer to make 10 years' worth of progress move forward in 5. I'm going to give you an overview of the whole activity, and then we can speak more specifically during question and answer of what you're interested in. So I'm going to discuss the purpose, summarize our recommendations, speak more specifically to the one that's on symptom management, and then go on from there. The Moonshot was announced during the State of the Union by President Obama on January 28th, and there a memo outlined the charge for this activity, and that includes accelerating our understanding of cancer, improving patient access and care, supporting greater access to new research data and capabilities for computational analysis, and to encourage the development of cancer treatments, identify and address any unnecessary regulatory barriers, and consider ways to expedite administrative reforms, ensure optimal investment of federal resources, and identify opportunities to develop public-private partnerships. And as you'll see, between the two groups working on this, we managed to address all of those. Vice President Biden ran a task force that included 18 executive branches, including the Department of Defense, Energy, Health and Human Services, the VA, Office of Management and Budget, as well as many others, to look at how to work together better in delivering cancer care and in cancer research, and to reduce barriers that were getting in the way of making faster progress. And I wanted to read what Vice President Biden said because I think it really focuses on what our charge was. I plan to do two things: increase resources, both private and public, to fight cancer and break down silos and bring all the cancer fighters together, share information, and end cancer as we know it. This is not a promise to make cancer go away, but it is a promise to try to accelerate progress to end cancer as we currently know it. The Blue Ribbon Panel in our final report, which is available at cancer.gov/BRP, I think that the introductory letter uses words I've never really seen in a cancer report before, which is that it describes a set of consequential recommendations for accelerating cancer research to achieve the ambitious goal of making a decade's worth of cancer research progress in 5 years and to bring the most promising science and clinical developments to cancer patients in the near term. And I hope that you'll see in the recommendations that we make the opportunities to do that. In addition to the Vice President's task force and the Blue Ribbon Panel, which was to deliver its report to the National Cancer Advisory Board, 7 working groups were identified that had co-chairs from the Blue Ribbon Panel, and there were members of the task force on the Blue Ribbon Panel and Blue Ribbon Panel co-chairs working with the task force to facilitate coordination amongst all of us so that we were actually all on the same page. And then there were parallel scientific and public engagement opportunities to make sure that those who could be involved had an opportunity to weigh in on those. The work groups had about 12 to 15 members, so when you put all of that together, we had about 150 individuals engaged in the working groups for the Blue Ribbon Panel. We were asked to create 2 to 3 recommendations that were opportunities that were poised for acceleration. Not that other areas weren't important, but that these provided unique opportunities. And then we met rapidly and regularly from April to July to come up with those. The final recommendations were asked to be between 5 and 10, so if you do the math between 7 work groups and up to 3 recommendations, we really were going to be challenged to do this, but it actually flowed very well. The recommendations are listed here. They are not numbered because we didn't want to convey any importance to number 1 versus number 10. We got it down to 10, and I'll briefly speak to each of these as we go through them. One is a network for direct patient engagement in a way to let people from the time of diagnosis know about possible clinical trials they could participate based on their tumor profiling. And this would be a way to increase the number of people participating in clinical trials. As you may know, adults only are about 5% involved in clinical trials versus about 70-75% in pediatric cancers, and we need to change that. Create a cancer immunotherapy network, therapeutic target identification to overcome drug resistance, and the creation of a national cancer data ecosystem as a way to share the data we already have or that we will be creating so that we can make accelerated progress. And there was a pediatric cancer work group, but in addition to that, we also had a thread of pediatrics throughout the other work groups as well. As you can see here, creating fusion, understanding fusion oncoproteins in pediatric cancer, because pediatric cancers develop differently than adult cancers, and there needs to be a greater understanding of how that works. And the one I want to take a few minutes to talk about is the symptom management research. The reason for that is one of the things what we agreed to very early on was that we would cover the cancer continuum from prevention and early detection throughout the cancer continuum from diagnosis, survivorship, and end-of-life care. And one of the greatest things that affects the 15.5 million survivors today is the residual effects of the disease and its treatment. Only about 10% of cancer survivors have absolutely no problems. Another percentage of people have problems, but that they're tolerable and minor and can be put up with. But there are other people who are really dealing with a lot of side effects from the treatment and from the disease itself. And that could be during treatment or after treatment is over or during palliative care or actually facing end-of-life issues. But one of the big issues is that patients don't always report them, or the clinicians don't always elicit patient-reported symptoms. And there are some measures now that can be used for that, but what we're really talking about is the integration of those so that patients have an opportunity to report the issues that are of concern to them, and clinicians are shown this information so that they can do something meaningful with that. And to loop around again to make sure that whatever interventions are used are effective in relieving whatever that symptom is. And if not, then to, again, revise the management strategies to get there. That combination of a feedback loop doesn't exist as smoothly or as well as we would like it to today. And with the advent of the electronic health records and patient-reported outcome measures, there's an opportunity to do that with existing evidence-based guidelines for symptom management and to identify those that don't exist yet that need to be developed. And I think this has one of the greatest areas to improve direct patient care for those who are already experiencing cancer. The next recommendation had to do with precision and prevention and early detection. And this group really wanted to focus on things where we already have the tools and we already have the knowledge, but not everybody is doing them. And that really has to come back to dissemination research as to how do we increase implementation. That includes HPV vaccinations, colorectal cancer screening, and tobacco cessation or prevention. And so those are three areas we know we can have a tremendous impact on cancer incidence. If we could implement these, we would really do a much better job of preventing cancers from occurring in the first place and also detecting them earlier. The last final recommendations include looking at biospecimens of people who have already been treated with standard of care, thinking that not everything has to be done in a prospective randomized controlled trial, that we can learn a lot from the data that we already have, and then creating a human tumor atlas that would allow people to study how tumors develop and grow and spread in a way that will yield understanding for new interventions for prevention and treatment. And then technologies that will be needed to be doing those tasks at hand. There were some demonstration projects that were summarized and recommended as paradigms to look at the things that we were talking about as far as prevention. For example, Lynch syndrome is a genetic inherited syndrome that puts an individual at higher risk for colon cancer or endometrial cancer. And people who are diagnosed with either of those cancers are supposed to be tested for that so that we could then work with their first-degree relatives to know about their potential risks so that they could be screened and possibly provided with genetic counseling if they're positive for that mutation. Another demonstration project that we're recommending is a pediatric cancer immunotherapy network because of all the new agents that are being brought out and showing some pretty impressive results, not having pediatric trials to extend that to that population. And then tumor pharmacotyping as a way to really measure on the tumor itself therapeutic agents to make sure that they're going to be effective before actually administering them to the patient. There were a number of cross-cutting themes that included how do we access and create the national network to look at the data, whether it's biological or clinical data, the cross-cutting themes about prevention whenever possible, the need to close the gap on health disparities, the development of biomarkers, technology, and preclinical models, data sharing, analytics, and predictive computational modeling, and collaboration, especially with public-private partnerships. So we wanted each of these recommendations to make sure that they could address some of these areas. The other thing that we did was when we identified issues that were system-wide barriers to moving forward, we pushed them back to the Vice President's task force to make sure that the agencies were at least addressing them. For example, was medical coverage and reimbursement preventing people from participating? How to get people to be more engaged in their care and participate in research. And you can see improved clinical trial systems, improved outcomes for children with cancer, data sharing, and then other incentives for insurers, industry, and academia to make this happen. And so they came out with their report, but in addition to our work at the same time, there was an ongoing effort to get scientific and community input to these, and there were a number of ways that people could submit ideas, and as you can see on the slide, there were over 1,600 ideas submitted. There were listening sessions at professional meetings, there were one-on-one public input, there were professional conferences and other listening sessions that were held. And in a qualitative summary about the 1,600, what would happen is they would be coming in weekly, and then they would be sent to whatever group was appropriate to include or address. But overall, they really were suggesting that on-the-cusp breakthroughs be invested, that the cancer research results be shared more broadly, especially with the public and with patients, and to make it easier to find and enroll in cancer clinical trials, and to focus on survivors and build on what works. And you can see the URL to see the whole report. And then on June 29th, the Vice President convened a summit in D.C., and then that was being held at over 170 other summits across the country, where about 7,000 people attended, where the activities were shared, but most importantly, there was the invitation to be part of the change and to help accelerate the progress with the opportunities that were going to be going forth. And I think that was very successful. So our report was submitted to the National Cancer Advisory Board in in September, and the Vice President's Task Force report came out October 17th. And this is one of the statements about it, which is that this whole effort has brought the entire cancer community, industry, and patients and families together in a way we haven't seen before. We're proud of the work generated by the Blue Ribbon Panel and its working groups, and look forward to seeing these exciting and powerful recommendations implemented and putting our action to work. I've been an oncology nurse for over 40 years, and I've been involved in a number of other efforts that were meant to look at how to make progress in cancer care. And I have to say, I've never been involved in an activity like this. And it does make me quite hopeful about what may come of it. Hopefully there'll be some funding announcements coming out for people to take advantage of implementation of the recommendations. The Vice President's Task Force came out with 5 major themes that mirror and echo what we recommended in the Blue Ribbon Panel, which included catalyzing scientific breakthroughs, unleashing the power of data, accelerating bringing new therapies to patients, and strengthening prevention and diagnosis and improve patient access and care. And so you could see how they interdigitate to move things forward. The other thing that was released with this report was that things that were already being negotiated or pledged to help accelerate progress. And this is just a small example of federal agencies and what they're hoping to offer as a way to do that. So each of the agencies is in parentheses next to what the activity is, including, which I really enjoyed, improving cancer survivorship through art with the National Endowment. And as you can see, there's others along in here as well. For the private sector, a number of companies have stepped forward to partner either with NCI or with others to try to address issues. And as you can see, there's a long list of here companies committing to improving diagnostics. Others are committing to alleviate inequities, developing new tools to do this work, especially around early detection, which is quite nice. And as you see here, the one thing I want to point out as well that really is relevant for people with cancer today is Lyft on this page and then Uber on the next page. I think it's Uber on the next page. Let's see, yeah, down here, where they are committing to help facilitate transportation to get people to their cancer treatments, which is a significant barrier for many. And as you can see throughout this listing, there are short-term commitments to make something big happening. my overall feeling, this activity has been an incredible bipartisan effort that I think that wouldn't have happened without the Vice President's vision to make this all happen. And it was an incredible collaboration of many, many people who have stepped forward to volunteer their time and energy to ask the question that we're rarely asked, which is, what could we do to accelerate progress in cancer and cancer research and cancer care? And so that's a summary of, in a 30,000-foot view visit of what we've done over the last few months. And I think the analogy of the moonshot, I would say that we've built the rocket ship, the NCAB put on a launching platform and pushed the button to launch, but the rest is yet to be. It's now really about making this happen, and I think we're going to hear about MK, about what those possibilities are. Thank you.
Thank you very much, Deb. That was a great overview of the whole Moonshot effort, and thank you for your work on the Blue Ribbon panel and the working group, because I know it was an incredible amount of work that went into that, and it's pretty impressive how quickly things came together between, from the announcement of the State of the Union to the forming of the task force and Blue Ribbon panel to putting out these two major reports. So I'm now going to, I know that there are some questions for Deb, but we're going to turn it over to MK Holohan first, and then we'll come back to questions at the end. MK is at the NCI Office of Government and Congressional Relations, and I've heard her give presentations on kind of the overview of what's happening on the Hill and the prospects for various different kinds of healthcare legislation several different times, and she does a great job of explaining what's going on. So we thought she could give us sort of a lay of the land of the landscape on the Hill and what might happen in the lame duck session that will be convened after the election. So I'm going to turn it over to you, MK. Thank you so much for joining us.
Oh, thank you. So, as you've just heard, this is really a tremendously exciting time, and I really echo those comments. And not having been part of the Blue Ribbon panel group myself, but having been able to hear the, my leadership in the Institute here at the National Cancer Institute, the cancer community, the researchers, this has been really quite remarkable in terms of just the way people have come together with sort of a momentum and a purpose that really the recognition from the President and the Vice President and the emphasis on the opportunities that are within our grasp in the cancer field has been really galvanizing, and that's been something that has been not political and really tremendously exciting. And the speed, having been in the federal government for some time and seen a great many working groups and task forces, the speed in which this group came together and the amount of time that people who are already extremely busy and overcommitted, what they put on hold to really immerse themselves in this is truly remarkable. And I think that what we're seeing is it's the momentum of the science which has sort of swept this along, and that is really something very exciting, and it's something that we are trying very hard to convey to Congress and really to the broader community, and we've had tremendous interest. Some of the things with some of the other aspects of funding and budget and how this, Deb referenced the executive order that created the Cancer Moonshot and the Executive Task Force. Some things have a little bit more of a political framing, and they've had a different sort of reception. And so I'm going to talk about those a little bit. And I just want to let you know there are sort of restrictions about, as a federal employee, there are things I'm not going to be able to talk about, and so the roles that your groups may take as you decide to talk with your members of Congress or with your other groups and how you want to approach things from an advocacy perspective. I'm going to give you sort of an overview of how I see things. I'm not representing the views of the National Cancer Institute. This is sort of my take on what I think might happen with the FY17 appropriation and how that relates to the Cancer Moonshot. So I wanted to sort of do a recap here. So we are in the final days, as we all know, of the 114th Congress. We are very close to Election Day. In terms of the current, so the fiscal year 16 expired the end of September. So what Congress did was pass a continuing resolution, which would continue the federal government operating at the FY16 level. In fiscal year 16, NIH received a $2 billion increase in their appropriation, which was quite remarkable. We've had tremendous bipartisan support in Congress with the leadership of Chairman Tom Cole in the Labor HHS Education Subcommittee in the House and Chairman Roy Blunt in the Parallel Subcommittee in the Senate. NIH has become, really a very strong bipartisan priority, and that's been a tremendously helpful thing for NIH. NCI has benefited from that proportionally with all of the other institutes and centers. But that we're coming into, 16 was a very good year for us. Continuing at the FY16 level means we just stay at that level unless and until Congress passes a spending bill that will give us an FY17 budget. So now we wait and figure out what they're going to do. The CR that we're currently under now expires on December 9th. The questions we have now are what happens? What happens next? Will there be more continuing resolutions to get us through until they can come up with an FY17, a big overall spending bill? They usually call those an omnibus spending bill, where all of the different spending bills are bundled together. There's only one that's been completed, 1 out of 12, so it would be 11 spending bills. Will there be, there's been some discussion of doing a series of mini buses. There is some disinclination among some members about passing one enormous omnibus because it's an extremely high number. It's a very difficult package to sift through, to really do a careful review of, and they dislike it. They dislike it from a fiscal responsibility perspective, and it's just sort of more unwieldy. With this little time left in the session, it ends up being just sort of the only thing that's practical much of the time. Minibuses are sometimes employed, not often. And then the big question relating to our discussion today is, what about Cancer Moonshot funding? How is that going to happen? These are still very open questions. So here is the congressional calendar. We are down in the bottom row, middle column. So Congress, the yellow bar represents when both chambers of Congress are back in session. So we have the presidential election next week. They come back Monday the 14th. We don't know what's going to happen with this presidential election. We don't know what's going to happen in the Senate. The Senate majority is, it's very close with the polling. There's lots of different poll numbers. They've shifted over the past couple of days. If the Senate majority flips, that's going to have effects on what happens with budget, what happens with FY17. We don't know what those effects are going to be, though. You can see how little time they have left. They have those days in November, and they have a recess for Thanksgiving. They have 2 more days. They come back. The continuing resolution we have goes through December 9th. So there's just a handful of days for them to determine FY17 spending. Continuing resolutions are pretty common. This is not anything unusual. They've been used in all but 4 fiscal years since 1977. They don't start new initiatives, though. If we were to end up with a full-year CR, for example, which is possible, although I think unlikely in this climate, that would keep us at the FY16 spending level for all of FY17. Things are more complicated this year because we have a change of administration. So this Congress will be deciding a spending bill that binds the next Congress and essentially the next administration. Continuing resolutions continue. They don't start new programs like a Cancer Moonshot program. There has been some controversy already earlier this year about what kind of continuing resolution. There was some issues in the House with some more conservative members, fiscal conservative members, not wanting there to be they didn't want a lame duck Congress, which is what we're going to have after next week. They didn't want a lame duck Congress to come back and pass a $1 trillion spending bill. They wanted Congress to pass a CR that went far beyond December, so then the next administration and the next Congress would come back in January, and then in March they would be able to look at passing another bill. So it would be people who had just been elected, who would be accountable to the voters, who would then pass a bill. That has not gotten any traction in recent weeks, and we don't expect there to be a discussion about a CR until, a CR that would bump things until March. This is not a year where I am predicting anything. This figure just shows the duration of CRs and sort of a historic chart of how often we have seen CRs, and this chart also shows how many. And the width of the bar indicates how long the CR lasted. So you can see some years that there were many, many, many CRs. You can see some there were a few very long CRs. So these are just ways for them to keep things going. Sometimes they'll pass a CR to keep things going for a couple of days. When this one expires December 9th, it is entirely possible there's a 3-day CR and then a 6-day CR, and then it goes all the way up until December 24th, and then they pass something late at night on December 24th. It has been known to happen. For the FY17 budget request, so sort of the way federal agencies get their money, there's a president's budget request that goes to Congress. There are appropriations hearings where the agencies go before the appropriations committees. They present the president's budget request for their agency. They answer questions from the members. During the hearing, they present testimony. They answer questions for the record after the hearing. And there's an opportunity for the appropriators to assess what's being proposed within the budget, new activities, ongoing activities, and then they go through their process as appropriators, come up with spending bills. The House and Senate then conference their bills when they get them out of their subcommittees and appropriations committees. And then the process, if it played out to its full conclusion, then they would pass a spending bill. Our bill, the Labor HHS Education Bill, is relatively controversial. It is usually the last bill to move. There's a lot of policy issues associated with our bill with labor, health, and education that are really often quite partisan. And so there are priorities. The parties have different priorities within our bill. And that is something that sometimes works against our interest in terms of getting things done quickly. For FY17, the President's budget request, which also created made room for the Cancer Moonshot and was accompanied simultaneously with this executive task force, executive order creating the Cancer Task Force, the way they were able to make that request and make a funding request for a Cancer Moonshot and staying within budget caps required some it was not an easy thing to do because of the budget caps that they were subject to. So what they did was, where I mentioned that we had a $2 billion increase in the NIH budget in FY16, the way the budget was structured, the request for 17 was to cut $1 billion of that discretionary funding that was added in 16, but to then add $1.8 billion in mandatory funding, which is not the kind of money that appropriators have access to. Mandatory funding, if you think of things like Medicare and Social Security, they're funds that are set into place by laws, not appropriation spending bills, and they require pay-fors. And so that is something that is a very different approach. NIH is funded through discretionary funding, not through mandatory funding. And so this is something that was a little bit of a political framing for something for this proposal. So that included $680 million for the Cancer Moonshot initiative. There were certainly other programs that were supplemented with this proposal for mandatory funds, but for our purposes, the $680 million of the Cancer Moonshot is what we're interested in talking about today. When the appropriators went through their process, they declined to. They weren't actually asked to cut, to fund the Cancer Moonshot. They were asked to cut $1 billion in discretionary funding. They declined to do that. What they did in the Senate bill was to increase NIH funding by another $2 billion. The House bill proposed a $1.25 billion for NIH, and the chairman of the House subcommittee has commented on more than one occasion that his number, he considers that a floor, not a ceiling, and that leads us to believe that when the House and Senate conference, they will end up at a higher number for the NIH. So we really don't know how this is going to play out. As I was mentioning earlier, we have an election playing out next week. The entire House is up for re-election. 1/3 of the Senate is running for re-election. Out of those 34 seats that are up, 24 are GOP held. The Senate majority is in question at this point. We just don't know how the election is going to play out. if Secretary Clinton wins the presidential election, the Democrats only need to gain 4 seats to gain control of the Senate, because the vice president who serves as president of the Senate would vote with the Democrats. So in the scenario where Secretary Clinton wins the presidency, then Vice President Kane would be voting with the Democrats in the Senate. So it is going to be something I think we won't know until maybe Wednesday morning of how things played out with the Senate race. That is going to be, I don't know what the effects are going to be about how the budget process plays out, but it's certainly going to have an effect. One thing I'll note here, I didn't include it in any slides, but you saw how uneven the numbers are for defending seats this time around in the Senate race. That's 16. In 2018, it's the opposite. The Dems will be playing defense, and they have a lot more seats up than the GOP senators do now. So, you're going to start reading about that very soon, and papers like Politico or The Hill will cover those, and those are actually really, if you're interested in this sort of thing, those are really worth a read. One of the ways that Congress and champions of NIH funding and people who are talking about trying to find ways to get funding for the Cancer Moonshot, one of the ways they're talking about trying to do that is through a bill called the 21st Century Cures Bill. And this is a version of this bill passed the House last June, not this past June, a year and a half ago. And this bill, there's lots of different pieces to it. For our purposes today, we're just going to talk about one section, which was to create one part of this bill, which would create an innovation fund at the NIH, and that would be funded by mandatory funding. I believe the numbers were about a $2 billion a year supplement for that innovation fund for a 5-year period. So it would be a set time frame of funding, and it would be to support a certain kind of project, so innovative projects, and that's the definitions of that are really not as material here, but this kind of an approach is what is being, has been being worked on about how we could maybe find a way to get mandatory funding or something to do with the Cancer Moonshot. So there's other areas of interest too that are being considered for this. There's Alzheimer's disease, there's Cancer Moonshot, there's concerns about opioid abuse and addiction, there's precision medicine. There might be a vehicle that would combine those surge areas is one way that Senator Alexander, who's one of the authorizers in the Senate on the Committee of Jurisdiction, the way he talks about it, these are things that there's a lot of support for providing additional funding for, and so what supporters in Congress are struggling with is how do we pay for it? Where can we find offsets that are palatable to both sides? There's a good amount of bipartisan support for trying to provide some extra funding for these areas, but finding pay-fors is a real challenge. It was pretty big news recently when Senator McConnell, the majority leader in the Senate, said that the Cures bill is a top priority in the lame duck. If the majority leader in the Senate doesn't think something's a priority and it doesn't want it to get floor time, it's not going to. So when Senator McConnell said that, that was a really important, that was probably late September. That was a really important thing. And so I think the stage is set if there's able to be a deal to be able to find the offsets and get something moved. The problem is we don't really know what the bill will look like. Just last week we saw, they called this, you've heard this term, October surprise, a couple of times in this presidential election. Well, there was one that included a letter from some fairly left-leaning groups, including the Center for American Progress, the AFL-CIO, some labor and consumer groups, that went to some of the senior Democratic leadership asking them not to move the 21st Century Cures bill because they're suggesting that it needs to include provisions to address drug pricing, which is a tremendously complex issue. I don't know what this means in terms of the possibilities of this bill moving. It may mean that it would have to be pared down and FDA provisions would have to be held for another day for another vehicle. I think that the momentum that we have seen in conversations is really significant, and I can tell you one of the reasons I think that there's more happening, that there actually is some serious momentum, is it's very hard to find out specifics. And when that's the case, it often means there's a really close hold on something that is, because there's actually a chance that it's going to move. What I included here is just, this is an event, the Center for American Progress, a month before they issued this letter, they were the first signature on this letter, had an event on the Hill with Senator Amy Klobuchar of Minnesota, talking about drug pricing. So this link in the slides, you can click there and watch a video of Neera Tanden, the CEO of CAP, and Senator Klobuchar talking about drug pricing. So that's going to be a lot of what you might hear as this issue makes its way into discussions in the Senate when they come back for the lame duck session. Obviously a really important issue, but not one that's within NIH's purview as a research funding agency. So here's some of the headlines we've started to see about the Cures bill, and these you're going to read following any of these articles. Stat and Politico. These are a lot. You don't need subscriptions to access a lot of these articles, and if you're interested in following some of the reporting about funding for the Cancer Moonshot, these are the kind of sources you're going to want to be looking at. I think we're starting to see things that are raising the issues. These are of concern. Is sort of, is this a vehicle? Is it possible that we're going to be able to get this done? The supporters of this effort are pushing really hard, but this may not be the vehicle. This may not be the time. That's something we just have to wait and see. What we're hearing this discussed as a revamped Cures bill, because the one that passed the House was so long ago and no one's seen a draft. What we don't know is what it means. It is certainly our hope that the Blue Ribbon Panel recommendations will be fully supported, because they are extraordinary. And what the community has come together, and the researchers representing, academia and patient groups and industry have really seized on some of these opportunities that are tremendously exciting. And what we get from the congressional engagement that we have at NCI is real pride in supporting the National Cancer Institute and the kind of work that we do here and that our colleagues do across the NIH. So the more tangible and specific and understandable we can make the opportunities, the more engaged and kind of committed we can have our support from our authorizers and appropriators in Congress. We're very hopeful that that's going to be something they're going to want to learn more about and support if there's an opportunity. But the political process, which we have to sort of watch play out, has yet to come together, and I think it's just going to be something until after this election. I would start reading very carefully after the election. In the week of November 14th, go to Politico.com, go to thehill.com, and you'll be able to get updates on all of this on a regular basis. And that's all I have for now.
Thank you very much, MK. MK has to leave us in about 7 minutes, so if you have a question for her, please type that into the chat box and we can direct those to her. And you can feel free to pose questions to either MK or Dr. Mayer. We've got a few questions that have been submitted in the chat box that are really great policy questions, but not really relevant to the moonshot discussion and the current kind of legislative update. So we would like to hold on to those and try to follow up with you later about them. And we really want to focus the time we have left on questions for MK and Deb about the moonshot and about what's going on the Hill right now. And so while we wait, I have a question for you, MK, before you have to go. So when you talk to members about the moonshot, what is their interest in it? What do they see as useful about it? What questions do they have that if we were going to talk to them about it, what would we need to know that they're kind of where they're coming from when they hear about the recommendations?
Well, so I think as with anything that any kind of new broad sort of program or proposal, the question is always, how is this not just business as usual? How is this different? And so one thing we try to emphasize again and again and give examples of is that this is not the full spectrum of this is not all of the opportunities, promising opportunities across the portfolio of NCI and all cancer research. These are areas that are ripe for acceleration, that are ready to have the kind of infusion of support that could make possible a decade's worth of advances in 5 years. And so there are some really, the more tangible your examples can be, the better. I've heard some of the representatives of the Blue Ribbon panel do just a terrific job. Liz Jaffe I've heard her speak about technology and in the way that has changed some of the opportunities within cancer research. So, and being, having been at NIH, and I'm sure all of you who have worked with, if you work in science and research groups, it's quite often that you hear people saying, and if you do it enough years, you hear there's never been a better time to be in fill-in-the-blank field. And I think it's absolutely true when people say it, because the field has developed to a point. This is sort of the highest level of that they've seen in their lifetime as a scientist or as a health communicator or whatever their role is. But one thing that we have, I think, done a good job of, and we need to continue to do, is to provide really tangible examples of why these areas are ripe for acceleration. And what I find with staffers and members alike is when there's an example that is very mechanical, tangible to them, they get it, then it makes sense. And so one of the examples I hear repeated back to other people after we've done it is circulating tumor cells. This is the idea that you can have early detection or monitoring disease by biomarkers in different body fluids. That is something that is people understand that. They understand the idea of going and getting a test and what that could do and what that might be able to do, what that can do now, what that could do in the future. So I think coming up with examples and knowing if you're talking to, I think the groups know how to talk to the regional interests, but, if someone has a particular interest in a type of disease or a disease population, then, really give them examples that are relevant to what they care about and what they already know about.
Great, thank you. And MK, another question from Tina. So she asked, if with the extreme bipartisan support for the moonshot, could it be its own legislation? Is that possible?
It's an interesting question. I think that we had incredible bipartisan support for NIH and for NCI within the appropriations world. I think NIH has had very good support from Congress across the board, but it has been a little bit less uniform, the approach taken. The appropriators were not really happy with the budget devices that were used, and I think they were used out of necessity. So I think the Cancer Moonshot, I'm not sure if I would say that the approach itself had broad bipartisan support. I think it is entirely accurate to say that the Blue Ribbon panel recommendations will have broad bipartisan support when they are fully understood. But I think it is probably unlikely that there would be a mandatory, an authorizing bill that would have mandatory funding just for a Cancer Moonshot, simply because of momentum. We have Vice President Biden, who's in the outgoing administration. He has put his energies behind this. And sort of, I think for something that would be a cancer bill, like focused solely on the moonshot, that's unlikely to come around again next year, for example.
And so a follow-up to that is with Biden leaving his role, what are the chances that the interest in this in the House or in Congress will continue without sort of his leadership and his position to really push this issue? I believe that he'll probably continue. He said that he'll continue working on this after he's no longer in the administration, but when he doesn't have that authority anymore, will members of Congress still have an interest in this?
Well, I think a lot of them have been real champions of cancer research already, and certainly he is held in really tremendous respect and has a lot of friends in Congress on both sides of the aisle. So I do think he will stay involved and committed. We never know exactly what path people are going to take. I think the momentum may be different, and he may, it may be that he creates something that is an extremely effective network or can work in different ways. I do think this created an incredible amount of visibility, and he was able to bring people together in a way that perhaps no one else could have. I don't know. So I think it's a complete unknown as to what I think the momentum will perhaps transform a little bit into a different, maybe coming from different levels. But I think Deb could comment on just the Blue Ribbon Panel momentum within that group of this tremendous expertise within this group. I feel like it is apolitical, number one, which is a positive when you're having these discussions, and it's grounded in science. And those things I think any administration, any majority, any member of Congress can work with. And there's no downside for them in wanting to support this. So I'm tremendously optimistic about going forward with this into, the next administration.
Great. Thank you so much, MK. I know you have to drop off, so we'll let you go, and we really appreciate your insight and your sharing your expertise with us. And now I'm going to ask Deb if you want to comment on this from your experience on the Blue Ribbon Panel and kind of how to make sure this continues forward after this administration ends.
Well, I think MK gave a great summary of the issues we're facing, and I think it's going to be up to all of us to hold whatever comes after next Tuesday, whoever's elected to carry on and carry forward this. And the reason it's so bipartisan, besides the sheer will of Vice President Biden, is because everybody's touched by cancer. And it takes an enormous hit. It's the leading cause of death, and there's no one that I've ever met when we talk about these things that hasn't been personally affected one way or another. So I think people get it. I think we have to make sure that we don't oversell it, because we're not trying to say we're going to make cancer go away. But I think we can say that we can make accelerated progress is a very real, achievable goal. And I think that it's not all about funding to NCI, although that's a big chunk of it. It's also about these private-public partnerships, and for each of us at our own workplaces, institutions, organizations to ask, what can we be doing to help with the acceleration? So I think there's going to be a lot of motion, and the question is whether they'll just want to be on the train as well. I mean, it would be a good move. I don't know that anybody would be against that. The real question comes down, where's the money coming from, is always the question.
Right, and so I know that you've heard, as I have, Dr. Lowy from the NCI talking about how they would sort of look at how they could, fund some of these projects given their existing funding, which is already stretched, of course. But do you have any more insight into how they might do that, even if they don't get the additional funding that's been proposed for the Moonshot to do some of these projects?
Well, I think it's not about taking money away from one thing for another, but it may be in directing what some of the priorities are to invite researchers to submit ideas for that under different funding mechanisms. There'll always be ways to get it addressed. It will just not be at the same accelerated progress as we're being asked to perform. So I think NCI is going to use this as a strategic document to think about what they're funding, but it's without that extra money, the progress is not going to be as rapid as we would like to see.
Great. Okay, so Deb, here's a question from Eric, who asks, how will the data sharing initiative impact the sharing of clinical trial data from cancer centers to PCPs?
I'm not sure if I'm quite understanding as far as on individual patients versus the results on full. So let me answer at both levels. I think that what we really need to be thinking about is how do we publicize and share our research findings to all those who are touched by those results, including primary care providers. Primary care providers and the rest of us are all working in healthcare systems that are changing rapidly. And we're very overburdened with taking on new activities. And so I think for primary care providers, they want to be involved in the care of their patients who have cancer. That's one thing that they're being asked to do, but they have many other things that's being asked. So we have to really start almost from the ground up and thinking about how people are trained, how systems are developed or function in a way that facilitates that kind of sharing of information around individual patients. Certainly the survivorship care plan was meant to do that. Uptake has been low and slow for a variety of reasons. So, but the other part of this is also engaging and educating patients and families to be more advocates for that communication to make sure that happens. That part of cancer care is going to be a long, slow process. But if we do some of these studies or fund some of these demonstration projects, we might be able to facilitate some of that.
Great. So another question from the audience was about reducing the regulatory burden for clinical trials and the speed for opening the trials, and then also about improving accrual and particularly at community-based trial sites. Can you talk about whether or how the Blue Ribbon Panel addressed both of those issues?
I'm not sure the specifics because I wasn't on that work group that really addressed clinical trials. I know that they were charged with thinking about how to increase participation, but also to think about other ways that we can get answers to our research questions without necessarily having to do prospective randomized controlled trials, which are very costly and time-consuming. Part of that's looking at data sharing of patients who are being treated with standard of care. The one thing I want to say is if you go to cancer.gov/BRP, you'll get the full report, but then on the left-hand column, it's each work group's report. And I want to encourage you to look at each of those because that has much more detail than the way the recommendations are positioned in the full report. So if you want to see what the clinical trials group was thinking, you'll see that in that recommendation. They're usually 2 or 3 pages long for each of them, but it gives you more context for the recommendation.
That's great. Thank you, Deb. And a couple of other questions were about getting a copy of the slides and the audio, and then also links to some of the additional information that has been mentioned. So we will, when we post the audio for the webinar, we will also post links to, I think, some of MK mentioned a few sources of information about what's going on the Hill that we can include, and then also the link to the Blue Ribbon Panel's report. There's also a short video about each of the 10 recommendations that you can watch that talks a little bit about why they're important. So that cancer.gov/BRP is a really great site for information about the recommendations and the reasoning behind them.
That's great.
So I think we are coming up at the end. Deb, is there anything else? And I'm sorry there's a couple of questions we weren't able to get to, but is there anything else that you would want to add about sort of the symptom management recommendation and how, if we talk to members of Congress about the Blue Ribbon Panel report and the need for funding, and specifically about why this is a particularly important project from our perspective, anything you would recommend when we try to sort of sell that as an important component of the Moonshot's recommendations?
Well, I think one of the things we can do is really encourage people to learn how to share what they're experiencing with their providers in a way that they'll hear them and be able to focus on them. And that's the patient-reported outcomes piece. So I think we can encourage people to really think about bringing written lists, asking if there's a form or a survey that they should be filling out before they come to be seen. And then also to say, are there guidelines for the treatment of these problems that they could be made aware of? I think that people who have had cancer experience a lot of things for a long time. And as somebody once said, we need to make the lives we save worth living. And if we don't pay attention to this, we're really compromising on that. But I think it's going to take all of us to keep talking about it, to raise it to the level that it needs to be, to get not only the funding but the attention of providers to address it in some way.
Great. Thank you so much, Deb. That was a really perfect way to end the webinar. I love that quote, we need to make the lives we save worth living, and I think that's really kind of what we're very focused on here. So thank you so much for your time and, again, for all of your work on the Blue Ribbon panel, and then for your time today to share that with us. We really appreciate it. My pleasure. Thank you. And thank you, all of you, for joining us. And this concludes our webinar. We will post the audio for the webinar in the coming days when we have a copy of it, and we appreciate your support. Thank you.
Thank you for your participation in today's webcast. Today's program is copyright 2016 by the National Coalition for Cancer Survivorship with all rights reserved. This concludes today's program. Thank you. You may now disconnect.